Hello, I'm Dr. Presh of Precious Life Hospital. Today I'll show you how we treat a dangerous high potassium level called hyperkalemia using the UK Resuscitation Council's ABCDE plan. Meet Chakabula, a 55-year-old on regular hemodialysis, just brought in by ambulance. Paramedics hand over Chakabula, who is short of breath and feels weak. A monitor shows a widened QRS and peaked T waves. A nurse draws blood. The lab shows potassium is 7.2 millimole per liter. Creatinine is 850 micromole per liter. The ECG and the labs tell us we have severe hyperkalemia. Airway is clear. We give oxygen through a mask to keep SATs above 94%. Respiratory rate is 22 breaths per minute. We watch for signs of muscle weakness. Pulse is 110 beats per minute. Blood pressure 150 over 90 millimeters of mercury. We start 2 large IV lines. GCS is 14. We note the ECG changes, peaked T waves, widened QRS, a classic hyperkalemia picture. Potassium over 6.5 millimole per liter is moderate, over 7.0 millimole per liter is severe. We aim to bring potassium down to less than 5.5 millimole per liter within 1 to 2 hours. Calcium gluconate 10%, 10 milliliter IV, over 5 to 10 minutes to protect the heart. You can repeat the dose if ECG changes persist after 5 minutes. Administer 10 units of insulin in 50 milliliters of 50% dextrose IV over 15 to 30 minutes. This shifts potassium into cells. Salbutamol, 10 milligrams, nebulized, helps move potassium intracellularly. Sodium bicarbonate 8.4%, 50 ml IV over 15 minutes only if the patient is acidotic. Repeat ECG and potassium every 30 minutes for the first 2 hours, then hourly. If potassium stays above 6.0 millimole per liter, give calcium resonium 15 grams orally or via NG tube, repeated every 4 to 6 hours. Because Chakabula is already on hemodialysis, we call the renal team for an urgent session. In centers without immediate dialysis, consider continuous veno-venous hemofiltration as an extracorporeal option. After the first round of medicines, the ECG normalizes and potassium falls to 5.8 millimole per liter. We keep the insulin dextrose infusion at 5 units per hour for another hour, monitor potassium every hour, and arrange the next dialysis session within 4 hours. We start a low potassium diet and review his regular dialysis prescription. We educate Chakabula and his family on foods high in potassium, the importance of taking his binders, and to call us if he feels weak or notices irregular heartbeats. A clinic review is booked for 1 week after discharge, with a repeat potassium and ECG. Quick recognition, the right medicines, and timely dialysis can save a life from hyperkalemia. I am Dr. Presh, and I am here to make life precious again.